Well, hello there. Welcome to this lecture on heart failure drugs. This is Professor White. Heart failure is a disease in which the heart cannot move blood forward through the heart. It's basically broken into a couple different types. One of them is systolic heart failure, and that's when the heart can't effectively contract with each heartbeat, so the blood doesn't really move forward. And then diastolic, and when the heart can't relax between the heartbeats. So both of these types, systolic and diastolic failure, decrease either the filling of the heart with blood or the ejection of the blood from the heart. In that case, we now will have a mismatch between supply and demand, right? Because blood carries oxygen and the body needs oxygen. The two biggest organs that need the oxygen, not saying that others don't, but it is the heart and the brain. So when a person is experiencing heart failure and the heart can't meet those increased demands, it reduces the oxygen available to other organs and instead prioritizes the blood supply to the brain and the heart. One of the organs that's not as dependent on blood supply, believe it or not, is the kidney. So often the blood supply is punted away from that, or shunted as we call it, and that can lead to acute or chronic renal failure. There are many causes for heart failure. They're listed here. If you look, some of the common causes would be hypertension, atrial fibrillation, diabetes, thyroid disease, somebody who's had a heart attack or coronary artery disease, cardiomyopathy. The list goes on. These are very common disorders that we will see in our practice, and therefore heart failure is actually a pretty common diagnosis that we'll see for our patients as well. Heart failure can be further classified as either left-sided heart failure or right-sided heart failure. And the signs and symptoms that you'll see for a patient who has these disorders varies by whether it's left or right-sided. It's important to note here the normal ejection fraction, which per textbook normal is 65%. Out in the wild or in the community, most cardiologists will give it a range, 50 to 70% being normal. But again, textbook, 65%. So left-sided heart failure often leads to those lung signs and symptoms. So pulmonary edema, coughing, shortness of breath. I always think left-sided lungs. Right-sided heart failure will lead to the signs and symptoms we see in the rest of the body. So right-sided equals rest of the body. And at that point, that's when you'll start to see the edema, jugular venous distension, hepatic congestion. So remember, left-sided means lungs and right-sided means rest of the body. The American College of Cardiology Foundation have defined for us the different stages of heart failure. They define them pretty good here in this slide, but let's take a look. So stage A is at the high risk of heart failure, but there's no symptoms of structural disease. Stage B is that they have structural disease, so something's wrong with the structure of the heart, but no symptoms. Stage C is when symptoms start to present. And stage D is end-stage disease, right? It means that refractory means treatments and things aren't working, and then they'll require additional treatments. Now, New York Heart Association has different classes, and these basically look at what is the effect of the disease on the patient and their shortness of breath and things like that. So class 1 is no limitation on their physical activity. So ordinary physical activity doesn't cause symptoms of heart failure. Class 2, slightly limited. So they're comfortable at rest, but ordinary physical activity does result in some heart failure. Class 3 is marked limitation. Again, comfortable at rest, but less than ordinary activities start to give them symptoms of heart failure. Class 4, they're unable to participate in activity without symptoms, and they also have symptoms at rest. And you can see class 3 also went to 3A and 3B, whether they started to have symptoms at rest. Our drug therapies that we'll talk about for heart failure really have a couple of aims at them. So the drugs that we're giving are to increase the force of the myocardial contraction, so make that heart a little stronger as it's pumping. So perhaps it just needs to pump harder to fight against that systemic vascular resistance. We have the positive chronotropic drugs, so these we increase heart rate for our patients. And the dromotropic drugs, these actually accelerate conduction through the electrical system. And I think it's pretty important to then take a look at the electrical system of the heart, which is in another lecture. So the drugs of choice. So many of the drugs that we use for heart failure, and they have changed over the years. It used to be digoxin was a first-line treatment, but as we've developed more medications, then digoxin has kind of fallen out of favor for that, and we won't see it as often these days. But it is still added if a person isn't doing well on the other medications or we don't have the therapeutic response we had hoped for. So the drugs that we look at are those that affect the RAS system, so the renin-angiotensin system. So those are our ACEs and our ARBs, beta blockers that end in LOL, some loop diuretics, the most common being furosemide, aldosterone inhibitors, and then finally digoxin. So ACEs, ARBs, beta blockers, those are our first line treatment for heart failure. And then digoxin is added if those are not successful. And just a quick nod to some ethnicity considerations. Bidil, or hydralazine with isosorbide dinitrate, is the first drug that was specifically approved and marketed to African Americans. Now, there is some controversy over the science that was used for this. However, it's important to note that this is out there and it is used primarily as a first line for African American patients, making sure that for hypertension and such that they are on usually hydralazine and isosorbide. So I just wanted to take a minute here before we delve into these medications to make sure you understand that all of the reasons that a person has heart failure and heart failure worsens and the signs and symptoms of the heart failure, which in turn tend to lead to more heart failure, are hypertension and too much blood volume. So the afterload is too high, preload, which is the blood volume, is too high. And remember what goes into the blood pressure. It's cardiac output times the systemic vascular resistance. So some of the meds that we work on are those that we're trying to decrease the blood volume and decrease blood pressure as a result. So the ACE inhibitors are a very common class of medications. You are going to see them. They are standard therapy and recommended very much by the American Cardiology Association for treatment. In fact, they are so highly recommended for treatment, these ACE inhibitors, that if a patient with heart failure is not placed on it, it is considered to be one of those quality indicators for heart failure management. You need to ask yourself why. If they're not on an ACE inhibitor, they need to have some sort of adverse reaction to it, and then perhaps they would be on the ARBs. So ACE inhibitors inhibit angiotensin converting enzyme. So that stops the conversion of angiotensin 1 to angiotensin 2. So this is working on that RAS system. So that decreases vasoconstriction, which decreases systemic vascular resistance, which decreases afterload, which decreases the stress on the heart. The other thing that it does by inhibiting aldosterone is it prevents the sodium and water resorption by the kidneys, so that decreases blood volume. which decreases stroke volume. Remember, cardiac output is heart rate times stroke volume, which decreases the cardiac output, which decreases preload, which decreases stress on the heart. Right? So diuresis. So all of that it has something to do with the diuresis, though these are not diuretic drugs. So the examples that you will see, most commonly lisinopril, enalapril, fosinapril, but they all do end in pril. So lisinopril is going to be our exemplar medication in this class. It is used for hypertension, heart failure, and acute heart attacks. Hyperkalemia is possible, so we do need to monitor our patients' potassium levels and be very cautious when we're using potassium supplements. Common adverse effects, again, dry cough, hyperkalemia, and it can actually decrease renal function a little bit. And like all ACE inhibitors, lisinopril is classified as a category C drug. So that's in the first trimester. It's category D in the second and third trimesters. This has been implicated in fetal death. So women who are pregnant should not be on this medication. So the angiotensin II receptor blockers, often called ARBs, they all end in sartan. So you can see the examples here, valsartan, losartan. They have really good beneficial effects that they decrease systemic vascular resistance. They work directly on angiotensin II. So remember, angiotensin II is a potent vasoconstrictor. So if we're blocking the effect of angiotensin II, we end up with vasodilation. One thing that I would like to mention is that we do not have patients on ACEs and ARBs together because that can be pretty dangerous. We don't want to block the action of both, but if an ACE isn't working, we tend to move over to ARBs. So we're going to look at valsartan. So the ARBs, and specifically valsartan, but ARBs in general, they share many of the same adverse effects as lisinopril. However, our ARBs are not as likely to cause that annoying cough. They are not as likely to cause hyperkalemia. But remember, patients should not be on both ACEs and ARBs. I grabbed this for you guys to take a look at, the side effects of the ACEs and ARBs. It's a nice little mnemonic to help you remember what's going to happen. So they're teratogenic. Remember, these meds really shouldn't be used in pregnancy. It can cause fetal death. Orthostatic hypotension. Drops in blood pressures as the patient is trying to go from laying to sitting, sitting to standing. Hyperkalemia, that dry cough. Angioedema. Renal impairment, and dizziness. A brief point about angioedema, which is more common with the ACE inhibitors. Angioedema is swelling, right? And we often think of swelling, it's around swelling along the mouth, the lips. We often think of that as an allergic reaction. However, with the ACE inhibitors, this does not cause a histamine release, so it's not an actual allergic reaction. It is a side effect, and when that occurs, if a person experiences angioedema and they're not having an actual allergic reaction, that usually stopping the ACE inhibitor is the only treatment that's needed. However, always be aware that with angioedema, your patient could be at risk for airway compromise. Angioedema can be very mild, or it can go all the way to life-threatening for the ACE inhibitors. Most of the patients, it is not life-threatening, and stopping the medication is indicated. So, brief spot here about the new kid on the block. This is valsartan sacubitril, which is Entresto. So you'll see that it's still commonly available as only at the trade. So you'll see it at Entresto. So this is a new class of medication. I'm going to say new. It's been out, I think, 2015 or so. Basically, what this does is it has the ARB and it adds with it sacubitril, which is a neprilysin inhibitor. So without getting all crazy into the patho and things like that, basically it blocks the receptors to which angiotensin II normally attaches, and then valsartan stops the harmful effects of the hormone on the heart, so reduces blood pressure by allowing the blood vessels to widen. So just like the others, it does have an ARB in it, so hyperkalemia can actually decrease renal function. It is not used in pregnancy, and it does have several interactions, so including our ACE inhibitors. Because it is an ARB, they should not be given together, and some NSAIDs. The beta blockers are used in heart failure. These are addressed in one of the other presentations that we have. But remember, beta blockers will block the sympathetic nervous system. This allows for better filling of the heart. It decreases the strength at which the heart beats a little bit and decreases the automaticity. So very commonly used metoprolol and carvedilol. Remember, blocking that sympathetic nervous system is what beta blockers do. The aldosterone antagonist. Remember, aldosterone is part of the RAS system. It's renin-angiotensin-aldosterone system. So if we can block aldosterone, we can block the sodium retention and the water retention. So decreases the edema that worsens heart failure. So we're going to decrease blood volume. So spironolactone is considered potassium sparing. It does reduce the symptoms of heart failure. But remember, potassium sparing means that the patient can get hyperkalemic. And then eplerenone or Inspra, not very common, not near as common as spironolactone, is selectively blocking aldosterone and the receptors there. All right, so this next slide is going to be on one of the other medications. It's a sinoatrial node modulator. So the sinoatrial node being responsible for heart conduction. It's up in the atria, the right atria. So basically, this blocks the SA node a bit, so it decreases the heart rate that way. This medication is not first line at all. This is going to be used in our patients who have already been on treatment and they are not getting the benefit, the therapeutic benefit to their medications. So if they've already been on the maximum dose of the beta blockers, or they can't be on beta blockers, this would be medication potentially for them. It's used only if they have a heart failure with the ejection fraction under 35. This can cause atrial fibrillation, can cause bradycardia, and other conduction abnormalities, so it can lead to dysrhythmias in the heart. And for this one, you do want to have the patient avoiding grapefruit juice. Phosphodiesterase inhibitors, of which there is only one that we use. Basically, it results in inodilation, so positive inotrope, vasodilation, and increases the calcium a little bit there for increased myocardial contraction. This is used short-term for patients with heart failure, and we should not be using this long-term. So as we go down here, take a peek at this, right? Milrinone would be the exemplar medication. It is used in an ICU setting for basically severe acute heart failure. It's only available IV. This must always be given via pump. Look at the adverse effects on this one. Cardiac dysrhythmias, low potassium, thrombocytopenia can affect the liver. Lots of interactions specifically with some other the meds for heart failure. So diuretics and digoxin. And the other thing that's of note is that you only want this milrinone into its line. In fact, one of the drugs that we give, diuretics, furosemide, if you were to inject this in the same line, it will cause immediate precipitation. Remember, ICU level of care, always on cardiac monitors. And literally, this is a life-saving drug, but it's for those who have acute decompensated heart failure. All right, we're going to go into the cardiac glycosides now. So these have been around a long time. Remember, these used to be first-line treatment. This is medications that were taken from foxglove, and I put a picture of what foxglove looks there. It's very pretty, but it is digitalis. So digoxin is the prototype drug we will look at, and we still do use it. It's not first line, like I said, but we still use it in heart failure and those who have atrial fibrillation to kind of calm the ventricles down so they don't have rapid ventricular response. All right, so what do these drugs do? So positive inotropic effect. So it increases the force and the velocity of the myocardial contraction. They have negative chronotropic effects, so they reduces the heart rate. So imagine this, it's slowing the heart rate down a little bit, so it's feeling better, but giving it a more forceful contraction. And then the dromotropic effect. So this is basically how long the cardiac pathway takes to cross from the electrical standpoint, right? So this prolongs refractory, or as we call it, resting period. Again, allowing the heart to feel better. So all of this to say that we have a better stroke volume, decrease in vein engorgement, increase in coronary circulation, decreases the symptoms that the patient experiences from heart failure, which allows them to have a better quality of life. Unfortunately, however, there's really no reduction in mortality that's been seen. Digoxin, one of the reasons it's fallen out of favor is because in order to be therapeutic, it has to be at a certain level, and it has a very narrow therapeutic range before it becomes toxic. So we do need to monitor their lab values. The normal digoxin values that we would like to see would be 0.5 to 2. If a person has hypokalemia, there is a higher risk of them having toxicity. And think about this. Many of the patients who are on digoxin are also on medications like furosemide. So let's look at the toxicity signs and symptoms. So their heart rate could be higher or lower. So this is why we report low heart rates under 60 and high heart rates over 100 to our providers. Seeing colors around lights is probably one of the most commonly tested items, those halos. So we're looking for visual changes in our patients. And if you do see that, you do need to assess for other signs and symptoms of digoxin toxicity, checking their heart rate, looking for the other signs, headache and dizziness, blurred vision. At that point, if your patient does have signs of toxicity, please do not give the medication. You need to contact the provider. So look at all of these conditions that predispose a person to digoxin toxicity. We already talked about hypokalemia. Using a pacemaker. Remember, one of the signs of digoxin toxicity is a high heart rate or a low heart rate. So if somebody has a pacemaker, that may mask that low heart rate. High calcium levels, liver dysfunction, people already have dysrhythmias, other diseases, because these are all things that can sort of mask and also lead into digoxin toxicity. As a person gets older, how they metabolize medications changes, and that can also lead to increased toxicity. Thankfully, there is a treatment for severe life-threatening digoxin toxicity. Most patients do not need this. Okay, this is for life-threatening digoxin toxicity. This is called digoxin immune fab, or Digibind. And this is for patients who have severe life-threatening potentials for having digoxin toxicity. Their potassium level is above 5. Their bradycardia is so severe that or doesn't respond to pacing, or if they have an overdose of more than 10 milligrams of digoxin. And interestingly enough, one vial of Digifab, so you see this 40 milligrams of Digifab, which is given IV, can bind 0.5 milligrams of digoxin. So if a person's got 10 milligrams of digoxin on board, then they would need to have more of this. All right, so let's look at the nursing care of digoxin. So we want to avoid giving digoxin with high fiber foods because it does bind with the digitalis, which decreases the absorption. If the patient has signs of toxicity, you want to not administer the med and contact the provider. Before giving a dose, you must check the apical pulse for 1 full minute. Okay? That's not the radial pulse, is it? It's apical pulse. Get your stethoscope out, put it on the patient's chest. Now, diuretics are addressed in another presentation just on diuretics, but for heart failure drugs in general, let's look at a couple of different pointers. Remember, before a patient is on these drugs, or if you have a new patient in front of you, assess their history, their allergies, contraindications for certain therapies. Make sure you notify the primary care provider if somebody's blood pressure is under 100. Many have holding parameters for that as they cause hypotension. Check the apical pulse for 1 full minute. Listening to their heart sounds and breath sounds. Remember, heart failure can affect the lungs and give us adventitious sounds. So we want to make sure that our patient is stable and actually improving on their meds. Monitoring the patient's weight and intake and output. Patients with heart failure should be taking a daily weight and letting their provider know about their weight gain. Checking their echocardiogram and electrocardiogram and their serum labs, okay? So you're responsible to make sure that we have the full picture here of our patients who are on these medications. Follow instructions in the dosage forms. Many medications are available IV as well as PO, including metoprolol and digitalis and cardizem and all sorts of our cardiac meds. So make sure you're following the instructions for administration. We spoke about the weight gain for patients. So here it is. Report a weight gain of 2 pounds in a day or 5 pounds in a week. Looking for what the med should be doing. We're looking for an improved assessment for our patients and monitoring for those adverse effects and responding appropriately. All right, as we finish up here, guys, I have a little cartoon for you. I want to thank you for your time and attention into this lecture, and hopefully you've learned something about the major classes of heart failure meds. Thank you.